So this little talk is not prepared specifically for this. This is work that has been going on that I thought would be relevant to present here, and I know that we have a collaboration going, or at least beginnings of a collaboration going, and this work may inform that collaboration as we move forward. So I decided to talk about hospitalizations and ER room visits that we've been interested in as part of the research that goes on at the US Renal Data System Coordinating Center. But before I do that, I thought it would be useful for me to provide a brief perspective on what the US Renal Data System is for those of you that may not be familiar with it. So bear with me. So why was the USRDS created in the first place? Many of you may know that dialysis became a life-saving therapy only as recently as the 1960s, although a lot of research and trauma and disaster-related acute rhabdomyolysis-related kidney injury was being treated in desperate circumstances, often unsuccessfully, but it finally became an outpatient therapy in the 60s, starting in Seattle, Washington. And then the big landmark, I think, decision was when it became an entitlement by Medicare. It's one of the few existing universal healthcare systems within the US healthcare system since July of 1972. Makes for very interesting reading, the history of this, how this came to pass. And naturally, since that time, it was anticipated that a few thousand people each year will be receiving dialysis as a life-saving therapy, and the government will manage it. But much to people's surprise, a lot of data began accumulating at the Centers for Medicare and Medicaid, and not much was being done with it. Initially, it was all paper-based and was piling up as files that gathered dust in some of the rooms at CMS. But alongside this, there were advances being made in computing and data management. The value of large databases and observational studies was becoming increasingly recognized. And finally, by a lot of lobbying by key individuals that I happen to know some of them, the US government and the kidney community at the time realized the value of these data, and the cost was building up alongside. In 1974 itself, the cost of dialysis was about well over $200 million, and it rose rapidly to the billion dollar mark, $1.8 billion in 1982. And as a result, I think the NIH leadership became willing to come out of its traditional comfort zone of supporting mostly basic science and some clinical trials at the time. And the USRDS was created as a result. And finally, also, I think an important aspect of the history is that the renal data system became one of the early tools for supporting researchers throughout the country. So it was, I believe, one of the first comprehensive data systems that started providing data, albeit at a modest cost, to anybody that would request that data, and it was made publicly available. There is a history of three major sites for this contract, actually two major sites for this contract thus far since 1988. For the first 10 years, it began here, literally. For 1 year, it was at the Urban Institute in Washington, D.C., but then the Division of Nephrology had, then Division Chief Roger Wiggins had the foresight to hire that person at Michigan so as to bring the contract over. So Philip Held was hired as the professor of internal medicine. It's a unique thing that a health economist was hired as a professor of internal medicine here, and the contract came along with him, along with his core team, as well as interested collaborators that had been working with him for some time on the Michigan Kidney Registry. So that's how the first US renal data system came to be at Michigan, and the Kidney Epidemiology and Cost Center was founded, much like what's happening here today with this ER center being founded. I think for 10 years we held it here, and as luck would have it, and maybe this is a pre-planned thing, that contracts tend to stay for 2 cycles at one place and then move on. From 1999 then till 2013, till very recently, the contract moved to Minnesota, led by Dr. Alan Collins, and he did a phenomenal job. Over the 14 years, the contracts were 7 years each. And then in 2014, we've helped to bring it back to Michigan, and I hope it stays here for at least 2 cycles. And John Ianian and some others in this room, Brahmaji and everybody here, would be key to this renewal coming up in 2.5 years. So just wanted us to be forewarned. The current contract is until middle of 2019. So the mission of the USRDS is to provide high quality epidemiology and surveillance of kidney disease for the entire United States. It also has a chapter on international comparison. So we do ask other countries to contribute data and bring it in as a chapter, which is increasingly becoming more and more detailed. Over 60 countries now contribute to that chapter, but it's primarily focused on the US of A, and it's an atlas of kidney disease. And the other mission is to conduct and stimulate research at the coordinating center and stimulate research around the country on kidney disease, and as a result inform public health priorities and policy. Those are the two key missions of key mission of the USRDS. I think if you look at the original document, the mission is a series of deliverables and tasks, but it boils down to two of these things. The major deliverables are the annual data report, which comes out each year in the fall, and previously used to be a book in 2 volumes, and now it's all web-based, detailing key epidemiologic aspects of kidney disease for the country, both end-stage kidney disease and the upstream CKD, as it's now called, with a lot of data analysis, production, database maintenance. Easier said than done, a big operation here, and the website maintenance and regular updates. And this is what the website face page, landing page looks like, and we keep changing colors, of course, each year. And then you delve into each of the highlights, the chapters, the reference tables, and then archive reports from previous years to get into it. Gets into great detail, step by step, and that's just the front page. It also appears as an American Journal of Kidney Disease supplement, an online supplement each year, so that authors get credit for the work that they do for the report as one document, not as individual chapters. And then we do, that helps us be stimulated to write papers to get recognition for that. So the major tasks again are research, conducting research at the coordinating center, assisting external researchers by provision of standard analysis files. We get huge data merge requests from big and small entities alike. For example, I think the largest data merge request is one that comes from the Department of Veterans Affairs for the entire VA, well over 45 million individuals that we need to link with the ESRD database, and we send that secure linkage then back to the VA. So the second half of this talk, I would take some time to just present one research analysis that was recently completed by one of our master's student, and young people that are so talented from all around the country come to Michigan, and we are lucky to get these good folks working with us. So Sabrina Zhang is the first author. She did this as part of her capstone project for her master's degree, MPH in epidemiology, supported by Hal Morgenstern, who many of you may have heard of, a famous epidemiologist that I've had the privilege of working with. Patrick Albertus is a medical student now, worked as an analyst with us before Kevin and myself. So we formed a core team and brought different strengths to bear, and asked the key question of whether there's any variation by day of the week and dialysis shift in terms of mortality. And the mortality question has been addressed in the past, so we asked the question whether hospitalization was also associated with day of the week or hemodialysis schedule. Traditionally, patients have been dialyzed 3 times a week, Monday, Wednesday, Friday, or Tuesday, Thursday, Saturday, and this regimen was thrust upon the community, I think, by pulling it out of a hat, literally, with not much clinical trial, just a practical logistic, avoid the weekends. During the week, people will dialyze and not on the weekends and so on. But it's come to stay with us, and I think it's a problem because it's not a physiologic, or it's not based in physiology. The kidney's supposed to work all the time, so it's an asymmetric, unphysiologic treatment modality and schedule right now. 3 times a week industrial strength dialysis by 2 privately owned companies now, incidentally, that makes it like a mill that churns out these people. There's sparse literature actually on day of the week and hospitalization or ED visits. There's a fair bit of literature now, at least 5 or 6 papers now, dealing with mortality early in the week and after the long gap over the weekend. The other problem with US dialysis, hemodialysis in particular, is that it's very short. It's short, efficient, high intensity, and subjects the patient to a considerable amount of cardiovascular stress. So all the problems therefrom. So we looked at the data to examine whether the day of the week or the hemodialysis schedule itself would be associated with all-cause as well as disease-specific reasons for hospitalization or ED visits. I'll quickly run through the methods. We only chose the outpatient hemodialysis patients with Medicare as their primary payer because we have all their claims data in our database. And we chose just 1 year snapshot for examining this phenomenon. There's a lot of patients available in that 1 year. We plan to look at several years to see trends and for consistency of effect. And the patients were identified and followed through the end of 2013. So it includes all new as well as existing patients on dialysis. And then we identified their hospitalizations and ED visits in the claims data. And for the purposes of this analysis, we only chose the principal ICD-9 code for their admissions and then tried to identify more granularly what that cause was. Using Poisson regression to estimate outcome rate ratios, using the Sunday, the weekend as the reference, and expressing them by day of the week and shift, and did a whole bunch of adjustments to make sure that we were ruling out or comparing like versus like. This was the total number of subjects, the hospitalizations and ED visits in these patients in 2013. So we have the Monday, Wednesday, Friday schedule and the Tuesday, Thursday, Saturday schedule. So roughly about over 100,000 people in each shift or each type of schedule, approximately 200,000 hospitalizations in just a little over 100,000 people, and over well over 100,000, 150,000 ED visits. So a lot of resource utilization, as you can see, in this very highly comorbid condition fraught population. And then this is, I think this is the main result, and I'll show you a few more variations on this theme. The x-axis is day of the week, and the y-axis here is the rate ratio with the Sunday actually as the reference day with the lowest mortality. The circle should be closer to the x-axis. And this shows the adjusted incident rate ratio of total all-cause hospitalization among the dialysis patients by schedule and day of the week. The red line is Monday, Wednesday, Friday patients, and the green dashed line is the Tuesday, Thursday, Saturday. And as you can see, there's very high mortality on Monday, in the Monday, Wednesday, Friday, as well as Tuesday, Thursday, Saturday patients. So Monday is a bad day, no matter what dialysis schedule they follow. And then there are peaks. Monday is a peak for the Monday, Wednesday, Friday, and Tuesday sort of is the peak for the Tuesday, Thursday, Saturday patients. There's also slight peaks at each of the days, so Monday being the peak and the Wednesday being a peak, and then Friday being a peak for the Monday, Wednesday, Friday, suggesting that the day of dialysis is also fraught with risk for these patients. And there's more work going on to see why that's the case, and a lot of work done in the area of cardiac stunning during dialysis session with functional MRIs and so on. So there is evidence that the dialysis session is stressful. There's intradialytic hypotension, lots of fluid being taken off, 3 to 4 liters at a time on average. And that's it's like bleeding a patient each time they come for dialysis with lots of volume, albeit with the refill from the tissues, but it does produce a lot of stress on the already compromised cardiovascular system. So there are these peaks early in the week. There are these peaks on the days of dialysis. And again, those are the main observations here. Then looking at some cause specific, the major peaks are from cardiovascular and infection, and both tend to track with each other. It seems like cardiovascular admissions and infectious causes as the primary cause for admission are tracking together. It makes you wonder whether they are intricately linked in terms of pathogenesis. fluid overloaded patients more prone to heart failure admissions and also infectious admissions. So is fluid overload somehow also a risk factor for infections or sepsis in these patients? Same day peaks is highly suggestive of that phenomenon, and there's some basis for that. The gut wall edema with endotoxin or bacterial transmigration could be a potential pathogenic mechanism for that. As you can see, the vascular access related hospitalizations are relatively flat. There's a little bit of excess after the weekend because people hold back. They don't go to the ER if they don't have to. But there is a slight early in the week peak, but then it's fairly flat after that. So cardiovascular disease or cardiovascular related, and we've looked at this more granularly, it's heart failure predominantly as opposed to MIs that result in these early in the week high rates from both cardiovascular disease. And again, you see the same peak on the dialysis days themselves, Mondays, Wednesdays, and then Fridays for the Monday, Wednesday, Friday, and also for the Tuesday, Thursday, Saturday on corresponding days. When we look at the event rate ratios based on patients that get hospitalized but not via the ER, so they don't come to the ER first, they just get directly hospitalized, there is an excess early in the week, and then it stays flat throughout, suggesting that perhaps planned admissions that do not require to go via the ER are relatively constant. It's mostly the emergent ones that are being driven by this long gap and then during dialysis stress. But otherwise, the non-emergent are relatively flat. And these are the ED visits followed by hospitalizations following the same kind of pattern as I showed you before, early in the week and on the days of dialysis for both the Monday, Wednesday, Friday, and the Tuesday, Thursday, Saturday groups. This is ED visits alone that did not result in hospital admission but required an ED visit, and to the point before that ED visits are driven by need predominantly, and again this shows the expected peaks and troughs. And this is again dividing these into cardiovascular, infectious, and vascular access related cause-specific ED visits without hospital admission. Much of the same really, so I'll skip over this slide. So the major findings are that higher all-cause cardiovascular, particularly all-cause as well as cardiovascular, and especially CHF, which I have not shown you the data on, and infectious hospitalizations and ED visits typically tend to occur after the long dialysis interval over the weekend. There's lower hospitalization and ED visit rates over the weekend after the week's dialysis sessions have been completed. And there's a higher hospitalization and ED visit rate on the days of dialysis, and hospitalizations that occur without preceding ED visits are relatively flat in their rates throughout the course. So these findings, I think, when combined with the early in the week mortality, calls for a serious reconsideration of this 3 times a week policy, and we've been trying to, I think it's all, the bottom line determines these things, and the dialysis companies, when confronted with these data, say who will pay for this extra session. They're already providing these extra sessions to patients in dire need, but not widely. I think dialysis ought to be delivered at least 4 times a week to all patients. I have many acknowledgements for the team at the coordinating center, the project officials, CMS, and our external advisory panel, and my team at the coordinating center here, which includes many of you at this talk. So thank you very much for your attention. No time for questions, I take it.
A question, and then maybe a hypothesis. If a patient undergoing dialysis undergoes a cardiac event, will they typically be admitted from the dialysis center or sent to the emergency department?
So they're often sent to the emergency department first, but they're provided with the acute resuscitation fluids or antiarrhythmic treatment, but they often land up in the ER, yes.
Then could this simply be a matter of ascertainment bias, that patients on the days that they're seen by providers, the days they get dialyzed,
right,
they are found to be sick, sent to the emergency department and admitted?
Yes. So, Bob, I think that's an excellent question. I think it raises the question of bias, but these events are happening mostly on the day of dialysis. That's a fact. They do occur at high rates in the interdialytic period, but mostly on the days of dialysis. And the frequency of intradialytic instability, if you like, not just hypotension, but instability, which includes hypertensive crises during dialysis, is about anywhere from 10 to 30, 40%, depending on the dialysis facility. The Japanese have a low rate of intradialytic events, and the reasons for that are unclear, although they think that dialyzing people flat. They have bed dialysis. They don't do chair dialysis. People are not sitting up when they are being bled or dehydrated with 4 liters. We have chairs. We have dental chairs that patients are sitting, they're watching TV or something, and we're withdrawing about 4 liters of fluid from them. And then the rates of hypotension, instability are pretty high. Electrolyte imbalance, cardiac arrhythmia. So there are real events happening. I've seen them. It's the way we practice dialysis is a bit of a disaster in and of itself right now.
Good question. What are the historical roots for this 3 times a week dialysis regimen that were sort of happened upon?
Right. So initially, actually, if you really go back in the patients that started dialysis early, they would do home dialysis. They would do long hours, 6 to 8 hours being the norm. And there was one center in France, Tessin, that held on to this 6 to 8 hour regimen 3 times a week, but slow, long dialysis. And they achieved, at least not by clinical trial, but by observations, pre and post, they reported excellent results. Their blood pressure control, fluid management, quality of life. They would describe their patients biking to the dialysis unit, eating during dialysis, drinking wine, red wine during dialysis, and so on. It would be dialyzed out quickly. They described excellent results, but the world ignored them. The world has consistently ignored that paradigm. Even in the US, early dialysis in Seattle area was long home dialysis, the older machines, but longer dialysis. But then the type of patient that was dialyzing in the 60s was very different from what the comorbidities that we see now. It was a younger, typically a 30 to 40-year-old male with pure kidney disease, no diabetes or very little by way of comorbidities, and they held on to this. I think it was a convenience and cost. And then there was also the NCDS study back in the 80s that tried to test the hypothesis that longer times are beneficial and so on. And the p-value of the result in the long treatment arm was 0.06. And the trial was stopped prematurely because there was a lower hospitalization rate in that arm, but the p was 0.06. And that result, despite being published in the New England Journal of Medicine, was ignored as an important finding. And the community focused on the urea reduction, the rapidity with which we can take off urea, and it's a small molecule, it's easy to dialyze. And they started developing equations to show that what is adequate in terms of urea removal. They forgot about the middle molecules and the other larger molecules that are also uremic toxins. And sodium removal actually is one of the main things. But the dialysis community became enamored by this KT over V concept, the urea removal rate or the urea reduction ratio that's converted to this dimensionless number called KT over V. And time became less of a factor. Time on dialysis became ignored. So short, high efficiency dialysis became the norm. And dialysis treatment times are shortest in the United States compared with Europe or the Far East and Japan in particular. So it's a mix of things, but that's how it's evolved. Yes, ma'am.
The United States, there seems to be only a couple of companies that manage somewhat monopolistically the community dialysis process.
Yes.
How do you see that as an interplay with the data? How does the data from those private companies impact the way we do dialysis in the United States?
So there's predominantly two companies that manage the dialysis, and then there's a bunch of others. So we have classified these into LDOs, the large dialysis organizations, and then the all others. Previously, they were classified more granularly, but they've been buying up these other small companies. There's a couple of not-for-profits, and their results are, in fact, somewhat superior to the for-profit companies. That research always keeps getting published, keeps getting criticized, because the N is smaller often in the not-for-profit companies. The data sharing is a problem. They don't share all the data. We have to pay to get the data. But they have mandated some data release by these companies each month. So there's a Crown web system. So we do get 12 data downloads from these large companies, which is great. So the data compared to the rest of the nation, their standardized mortality rates and so on, are slightly higher than the not-for-profit. But again, you can't really compare these based on the standardized mortality rates the way they are calculated at present. Overall, the good news is the mortality rates have been going down in the dialysis and ESRD population. But whether that's a background effect, whether that's everybody's mortality rates are going down, which is true, or whether that's specific to interventions or practices that are improving over time, is unclear. We're trying to do some empirical work to see whether those differences are true practice improvements. I think there have been some big policy shifts, a greater move to place vascular access in the form of an AV fistula, which is the more desirable form of access, not catheter, avoid catheters. So fistula first, catheter last is a big policy mantra since the mid-90s, actually early 2000s, that has, I think, resulted in significant improvements. We see an inflection point there. Then there was most recently a bundled payment system that everybody thought would be a disaster but anemia management actually, it resulted in lower usage of erythropoietin in these patients and lower hemoglobins, but mortality rates continue to improve. And we're trying to see if that's another inflection point in improving practices. But the comorbidity profile is changing. We do get that data at baseline and then through claims for the prevalent patients. But, that's shifting as well, and whether that is something to do with the falling mortality rates overall and falling hospitalization rates, incidentally, although this asymmetric phenomenon is continuing to take place. Does that answer your question? Okay.
So to follow up on that question, so it sounds like there is data sharing at this administrative level to your database. Something that we see clinically is no clinical data sharing. Now, maybe that's only true in Southern California. I don't know if it's true throughout the nation. But is there any effort to try to get real-time data to inform what's happening in the ambulatory and inpatient settings? The ER will get the data sheet when the patient is sent over, but that is not any kind of continuity.
I think the data sharing this is a very good example where it was mandated. It was really by policy. Everybody on dialysis had to be registered. It became because CMS was going to pay for it. So there was some enforcement in the beginning, might have helped. There's a form, there's an intake form, there's a medical evidence form, and they enter the data. But real-time data sharing is a problem. Again, it's only taken place by enforcement to some degree, by mandating it, and only on a monthly basis from the dialysis units. The real-time data from the dialysis equipment is not coming to us. That's something that we are trying to obtain, but it's harder to get. It's much more difficult to manage also. It will be a lot of data, that's true. Claims data is the other data that Medicare, CMS certainly shares. Private insurers don't share that data with us, so we have a gap in our database as far as private payers are concerned. But your other point about data sharing from the pre-ESRD phase, or the chronic early stages of kidney disease and the ER and all those are subject of another system, the CDC-funded CKD surveillance system that we are also involved with, and we're trying to get data from a number of sources, publicly available sources that sometimes we have to purchase, sometimes we get through agreements. But it's tough to get all the data. But I think surveillance is critical, and I was listening to the talk just before me, and for disaster preparedness, I think one of the early things we would do some surveillance of what's happening in all kinds, at all levels. But surveillance is a bad word in the modern day context. But without that, you can't focus on areas that require prevention of any sort, disaster, acute or chronic. So I'm not sure if I've answered all the entire question, and whether maybe we can have an offline discussion about it. Thank you.
Thank you so much.
Yep,
We're
you're
going to
welcome.
take a break.